Thank you so much, Gil. Yes, and we will tell you stories if you'd like. Um, and we're going to take questions after both of our speakers go through the abstract, so you have an opportunity to ask questions and after the state-of-the-art talk. So our next guest speaker is Dr. Niru Bonthala. And Niru is the Director of Women's Health and IBD and Associate Clinical Professor of Medicine at the Center for Inflammatory Bowel Diseases with us at UCLA. And Dr. Bonthala sees complex Crohn's disease and ulcerative colitis patients for second opinion consults, as well as focusing on the intersection of IBD, LGBTQ+, and gender health. And her main focus is the clinical care of women with IBD and looking at this population, including IBD at high-risk pregnancy clinic with maternal fetal medicine, an IBD menopause clinic with certified menopause gynecologist, and an IBD fertility preservation clinic with reproductive endocrinology and combined contraceptive clinics. So she's created these 4 multidisciplinary clinics, which is really amazing. And her research interest is in the clinical outcomes and implementation of care in these underserved populations. So now Nira will go through her abstracts and then a state-of-the-art talk, but I'll introduce that next.
Thank you all. Thank you to the course organizers for inviting me. I apologize for sitting down. I had a unplanned abdominal surgery on myself a few days ago. So I am still recovering a bit, but I am incredibly excited to be here today. And I want to give you my top 10 DDW 2024 IBD abstracts. And like Dr. Melmed had said, we had split up the talks to, or the categories. So mine will focus on diet, environmental, epi, observational studies, some cool tech stuff, and some adverse outcomes. So I really wanted to pick things that were going to be very pertinent that either your patients will ask you or are moving the field forward on, areas that we're concerned about. Okay, so I've done the slides. Basically, there's about 3 slides per abstract, and these were all wonderful oral abstracts. And just to set it up, get to the findings, and then give you sort of a clinical takeaway from it. So the first one is to look at diet. Patients always ask about diet. So this was a wonderful study that was done from Israel, where they basically had everybody who were initially diagnosed with Crohn's disease to go through a Mediterranean diet course with, and they eventually just see how they did. All right. So some of the slides are a little bit busy, but you will have them for your own reference if you want to look. So there was 271 patients with newly diagnosed Crohn's disease, predominantly ileal or ileocolonic. They were predominantly inflammatory, and they also used regular standard of care therapy. So about 70% were on biologics. And what you can see is that they also asked them to do a Mediterranean diet. They randomized them into this. And they saw that those who were adhering to a Mediterranean diet had a whole host of really, really positive factors, okay? So what they found is that those with newly diagnosed Crohn's disease who were put on a Mediterranean diet really had a less complicated Crohn's disease course. They ended up having much better fecal calprotectins, CRPs, their Crohn's disease activity index. They had much better microbiome changes. And so I want to kind of say to you, when patients come, especially when they first get diagnosed, they feel quite hopeless and they want to know, what can I do? This is one tool you can show to give them, in addition to the biologic therapy that you may prescribe, or in addition to other things, consider recommending a Mediterranean diet. How about my number 9 is on environment. So patients always ask when they get diagnosed, well, is there something I can do to prevent my kids from getting this? Is there something I can do for protect my family members from this? So this was a really wonderful study that was kind of a global study, doesn't include the US, but it was a very global study, and we're a very global population in Southern California, and they wanted to determine environmental risk factors for IBD, all right? And so what they did was they did a population-based case control study, and they looked at 723 patients who were newly diagnosed with Crohn's or ulcerative colitis, matched them with healthy controls in their general environment, whatever country they were from. They did not include any family members because it would be the same microbiome type of changes. And well, what did they find? So they found things like stress. People who had stress prior to had a higher risk for ulcerative colitis or Crohn's disease development. People who engaged in physical activities had a lower risk for development for ulcerative colitis or Crohn's. People who ate, higher, healthier foods, we'll call it, so things that were more vegetables, legumes, oily fish had lower rates for developing this. People who had a lot of food additives, processed food, had a higher risk for developing this. So I think, one of the takeaways from this is that to the best that we can, obviously manage any of these things. If a patient comes and asks you, well, what can I do to help my kids maybe potentially stave this off? There are some lifestyle factors. Patients are really looking for it. So to maybe try to say their best to try to themselves decrease stress, increase physical activity and dietary factors, as they may be important potential modifiable factors. All right, number 8. So now we're going to shift a little bit from the diet realm into complications of diseases and actually really complications of the medications we use to treat Crohn's and ulcerative colitis. So the first one I want to talk about, my top 8 one, is patients with inflammatory bowel disease are at increased risk for complications of herpes zoster. So this was a wonderful study that was done from University of Wisconsin, and they basically looked at this really large data warehouse called Optum, and they wanted to see if patients with IBD are in increased risk for herpes zoster due to their disease state, and to look to see if there are certain medications that are going to be causing them to have this increased risk. So they found patients with IBD, they matched them 1-to-1 to those without IBD, and then they analyzed them from 2007 to 2022. So a nice long period, all right? And then what did they really find, all right? So they really found that those with IBD compared to those without IBD, much higher risk for herpes zoster and all the complications for herpes zoster. And what about some predictive factors? You may think things like, well, maybe a biologic, maybe they're a higher risk for it, maybe things that are, if they're on prednisone. So the main ones that kind of came up in a multivariable analysis was definitely prednisone. So patients who are on prednisone are higher risk for it as well. And then when they looked really kind of throughout, and the main ones that came up also were age. But one of the things I really want, and anti-TNF therapy, but one of the ones I really want to kind of point out is that, they concluded you definitely are at higher risk for herpes zoster than non-IBD controls, but that, and it's very common to have complications up to 16% of the time, but that they really want to emphasize the point that, right now there is a non-live virus vaccine that is FDA approved for all adults over the age of 50, but really for those who have IBD and those, especially if they're on advanced therapies, it is approved for those over the age of 18. It might be a little hard for some of the pharmacists to accept this, but in general, they are approved. So they recommended to really consider this non-live virus vaccine in IBD patients on advanced therapies who are older than 18 to protect them from these complications. All right, number 7. So my top 7 here. So this one, you'll see a theme here. This is on kind of safety of medications for the next few. And this one is on biologics and JAK inhibitors, decreasing major cardiovascular events in IBD patients. So this particular one from Medical College of Wisconsin, they looked at this large TriNet X US research network that has, 17 million people, patients in there. And they basically took out about 20,000 patients who had IBD who are on anti-TNF, about 5,500 on anti-integrins, another 6,000 on ILs, and another 1,000 on JAKs. And they wanted to look and to see what are the rates for cardiovascular events in these IBD patients on various therapies. And what did they find? So they adjusted for a whole host of things, right? Because you have to adjust for things like age, sex, cardiovascular risk factors, and history of any cardiovascular diseases, et cetera. But generally, what they found is that you can see over here the anti-TNFs and had actually a lower rate for PCI or CABG or composite MACE outcome, and the anti-integrins had also a lower rate for the composite MACE outcomes. And the anti-IL-12/23s and the JAKs, they really weren't any different from the just baseline risk. So in their conclusions, they said that, JAK inhibitors, which is what we were really worried about, didn't show any statistically significant increased risk for MACE events in the overall population. TNFs were actually associated with a decreased risk for PCI or CABG or composite MACE, and that anti-integrants were associated with a decreased risk for composite MACE. So I think this is actually very reassuring data. Now, there is a little bit of a caveat. This is for all comers. And so they looked at, in general, the entire population. They are going to look more specifically at older populations and then populations that may have slightly increased risk factors. But I think overall, this is a better reassuring study in general. My number 6 is oral small molecules are not associated with an increased cancer rates in IBD patients. So this one, again, comes with an agenda, I think. The course directors for this particular oral session at DDW really put together all the best abstracts for the oral small molecules, I think, to try to make a case for the FDA to drop some of these warning labels that they have on there. And so one of them was also to look at just safety of these oral small molecules and rates of cancer, because we don't have a great study looking at that. We do for other IBD, but we don't have it for this. So they used, this one is from Cleveland Clinic, and they used that same TriNet X multi-institutional database, and they looked for about 5 years. So they looked at adult patients who received oral small molecules, which were either TOFA, UPA, or ozanimod, and they compared them to those who did not use these. And then they also looked at those who received the oral small molecules, and they compared them to those who were on biologics, the ones that we traditionally use. And what did they find? They really found that there was no increased risk for any cancer rates in those who used oral small molecules compared to those who are not on any therapies and compared to those who are not who are on biologics. Okay, and then you may say, okay, well, increased age is going to increase your risk for cancer. So how about in older patients? They did a subgroup analysis for those who were over 50. And I mean, you can call whatever you feel oldest, but they said 50, and there really wasn't any increased risk there either. All right, so again, a reassuring study. So here, their takeaway was that they did not increase the risk of malignancies, no increased risk in older IBD patients either. So these were really quite reassuring. All right, my number 5. So this one is on pharmacologic anticoagulation is protective against recurrent VTE events associated with JAK kinase inhibitor use in patients with prior thrombosis. So this one, I have to say, I was really excited to see this one. Excuse me. Because we always run into these patients who are really quite sick and you want to use a JAK inhibitor, and perhaps they've had a thrombotic event in the past, or you feel like they may be high risk for a thrombotic event, and you always feel, well, how safe can this be, for these patients, and should we take JAKs off of the table in this regard? And this is a small study, and I will say that this was from Hofstra University, and they looked through a large database, and they didn't find that many patients, I will say. But they was in 2 arms, those who are on JAKs who are not on anticoagulations, those who are on JAKs on anticoagulations, were only 32 and 47 patients. But this is the largest body of evidence that we have. You can see that most patients who were on JAKs and anticoagulation, they had some sort of hypercoagulable disorder, but there was otherwise no really significant differences between the groups. But when they looked through everything, they found that having the anticoagulation really did decrease the risk for recurrent VTEs, so it was quite protective, all right? A lot of these patients were in the rheumatologic realm, not the IBD realm, but it was, I think, something that we can extrapolate to say that in some patients that are either high risk because of a genetic predisposition or high risk because of a history of recurrent or a history of a VTE, or you feel like they are high risk for a VTE, to consider using concurrent anticoagulation with JAK inhibitors. All right. Now for a couple of fun ones. This is in the tech realm. So there were many, many tech ones this year at DDW, and they were actually a lot of fun to watch because it almost felt like you were on Shark Tank, the way they were kind of pitching some of these oral presentations for it. I picked a couple because I think they're just kind of emblematic of what's going on, but I could have picked many. Number 4, I'm going with is longitudinal assessment of a sweat-based TNF alpha in inflammatory bowel disease using a wearable device. So I would say this particular abstract looked at a particular wearable device that you can patch on. As it's a sensor, it's a patch, and it basically just reads out the sweat through a Bluetooth app. And the sweat biosensing, they're able to check things like CRP, IL-6, TNF alpha. And what they were able to show in this very small sort of pilot study is that basically they can tell the difference if somebody has IBD or not based off of a TNF, and looking at IBD versus healthy controls, they can see the difference of these various levels of sweat, CRP, and IL-6. And so it's kind of cool. Is it really going to make a difference at the moment? No, it's not. But I think it's kind of a nice way to see that where the field is heading. There was also another study that I was debating putting in there, but I'll just briefly mention, where they looked at heart rate variability to look and see, because a lot of people have, smartwatches, smartphones, so they can, or the wearable devices that are a little bit more accessible. And they found some differences in heart rate variability could predict whether somebody is going to go into a flare. And so I think these are things that your patients may see in the lay press that is coming. But I would say the general clinical takeaway for these is that, they're promising, but still in the early phases. And then my number 3, this one was a really fun one. So this one is a robotic pill. And they developed it's a phase 1 study to look at a orally administered robotic pill reliably and safely delivers an ustekinumab biosimilar with high bioavailability relative to subcutaneous ustekinumab in healthy human subjects. So this was done actually with Dr. Van Dam at USC, and basically what they developed was a pill that they would swallow, and then in the stomach, the enteric coating protects the robotic pill against the gastric pH, but then once it gets into the small intestinal lumen, the intestinal pH then allows the coating to dissolve. And then what happens is that moisture enters this robotic pill and triggers this chemical reaction, generating the CO2, and then this balloon inflates. So this balloon inflates, and then this needle is inserted through the intestinal wall, and then the drug is delivered. And then what's great about this is then after that, it just dissolves, completely dissolves. It's not something it's not like our capsule endoscopies that you see in the toilet. It's gone. So that was the theory behind it. They did some, they basically these are all healthy volunteers, and that they were 88% success rate for the deployment of the pill. 100% of the participants were able to swallow it. And the majority said they didn't really have anything, difficulty swallowing it. But how was it? How were the pharmacokinetics? They were pretty good. So the bioavailability was at least 84%. So this was just a one-time pill and a one-time injection they compared it to. Now, and the rates of adverse events were really nothing, So this is still very early. It's a phase 1. And I think some people at the conference were debating, is this a problem that needs to be solved or not? And I will say, as my father-in-law came to, every time my father-in-law comes to visit, he would rather take 30 pills for a diabetes medicine versus 1 shot a week, right? So yes, anything orally is always, I think, something the patients are really looking for. So I'm hoping this kind of accelerates through. And then my last 2, so my top 2. So this one is on the elderly population. So this is outcomes of acute severe ulcerative colitis in elderly, a multi-center experience. So this was done from our Mayo colleagues, and they took a look. It was a retrospective study. They took a look at all the disease courses in patients who are older than 65 who were hospitalized for acute severe UC. And why am I kind of bringing this up is because, we're always taught like there's a bimodal, right, distribution for IBD. And these days, patients are living older in general. And so it's not uncommon to have many diagnosed at the elder age. And you might feel because they are elderly that we want to be a bit more careful with them. And I think the data from this study is going to show that we want to be just as appropriately aggressive. So they had 120 patients, and the mean age of diagnosis was around 64. They were admitted around age 71 for the most of them, but a third of them only had UC for less than a year before they were hospitalized for acute severe UC. So do recognize that a third of elderly patients can really come on fast and flame really fast. This process of senescence that happens to the cells can also really boost flares. So be careful with that. So what they found was that, unsurprisingly, they had high fecal calprotectins, a high rate of C. diff, 21%, Mayo endoscopy score of 3 in 84%, which again goes with acute severe UC. But one thing I wanted to kind of really point out is that the colectomy rate was pretty high, 25% with the index hospitalization, 8% within 30 days. And the mortality rate was actually also fairly high, within 30 days, 3%, and within 1 year, 8%, right? That's a high amount. Predictors of colectomy were if they were severe enough to use anti-TNFs or they required anti-TNF, but also prior use of steroids, which a lot of patients were on. So I think a lot of patients will get put on steroids initially. So we really want to kind of be careful with not overusing and over bandaging with steroids. So for them, they really wanted to stress that rates of colectomy and mortality are high in older patients with acute severe UC, and that we really want to be appropriately aggressive, and that a lot of them, 1/3 of them, had a disease duration that was less than a year. So this can happen fast. And then my number one abstract was on safety and clinical effectiveness of GLP-1 agonists in an IBD patient. So GLPs, I think, are the wave of the future for many patients, whether they have any chronic medical IBD or not. And so I think everybody is a little bit hesitant when they have IBD because they have such predominant GI symptoms. And I think this is actually a really reassuring study that will show that GLPs are actually pretty well tolerated. So this study, they were looking at the adherence to GLP and how well the GLP agonists work in patients who have IBD. And so they looked at patients who have either Crohn's or ulcerative colitis, and this is from Penn. And they looked at for at least 6 months. And they looked at, and they wanted to make sure that there's no change in any of their IBD treatment at all. So this was just stable patients who had IBD who were put on GLPs. And they had a fair amount. They had patients, there was 245 patients, this was largest. Most patients were on it because of diabetes, and most patients had IBD for a very long period of time. And there were, a smattering of patients on all sorts of therapies. And what did they find? They basically found that, one, it actually worked really well. In general, patients had a pretty good response to weight loss for these medications. And adherence-wise, they tolerated it actually pretty well. So there were some patients, the majority, did fine, but about 8% had nausea, vomiting, diarrhea. But for the most part, 83% of patients were able to continue it on for at least 3 months. So that's pretty good. And interestingly, they actually found that the CRP is less in patients who were on GLPs. And again, they didn't change their IBD medications at all. And that was statistically significant. The fecal calprotectin was also down, but not statistically significant. They had some postulations on perhaps why that could be the case for it. So their conclusions are written here, but my clinical takeaway is actually GLPs are generally well tolerated, and I'm okay with my patients starting them as long as they start very slow and they ramp up very slow, just so that they have some, they can get a good sense of where they're at. So I just wrote down all of the top takeaways for you guys for my top 10 for this, but it was a fantastic conference. It was really hard to just make it down to the top 10. If there's other things that you guys are thinking about, that you were wondering about, Dr. Melman and I went to like every single thing. So please do come and ask us, but thank you for that portion.
Thank you, Niro, and thank you for being a champion and still coming to this conference. We appreciate it. And we're going to do questions. And do you have something you want to say here? Oh, no, we're still going to do the state of the art. So Gareth and I are still trying to get our shtick down after all these years. So we're going to do the state of the art talk with Dr. Bonthala. And if you look at the title, let's see, you have your clicker. So it's, when you see the IBD XX, that's referring to chromosomes. So it's not like we're still waiting for the title. IBD XX, a comprehensive approach to inflammatory bowel disease care for the female patient. And for those of you who don't know, obviously, Dr. Bonthala is an expert in this, and I think having specialized expertise and learning how to approach these patients with kind of sensitivity is really important. So thank you, Niru. And then after this, we'll do questions for both of our speakers and Dr. Melman. Thank you.
Great. Thank you again for inviting me. This is a talk that is a passion of mine, so I'm really excited to give it. Those are my disclosures, but I also like to give a personal disclosure in this particular talk. I married my childhood sweetheart, who just so happens to be a high-risk MFM, and I have 2 preterm kids, so I know what when I counsel patients, what a 29-weeker who spends 8 months in the NICU, comes home on oxygen and a G-tube, what that looks like. And my mom is a neonatologist, so I kind of breathe this from there. So we're going to go through and we're going to cover a lot, but kind of a higher overview. The majority of the talk will be spent on pregnancy, and you'll notice I didn't give any DDW updates on pregnancy. It's because they're all in this talk, so that there's also going to be some bonus there. So why is this an important topic? I really like showing these set of slides to kind of show, the incidence and prevalence of IBD is rising. We see that all the time in our clinic, and it affects a lot of women. So the updated ones are 1.3 million women in the US, right? So this is going to affect, you're going to see somebody with has a question about this every single day in clinic. And we know that IBD is a complex genetic conditions with environmental influences. And so like we talked about earlier, there really are some impacts that maybe we can do. We know that pregnant women with IBD have a less diverse microbiome. And we also know that infants born to mothers with IBD have a shift towards this sort of less diverse and dysbiotic microbiome. Those are wonderful studies that are being done by the group in Mount Sinai called the meconium study. And they're going to have such wonderful things to share over the next several years with us. But what they're already starting to show is that we can actually mitigate some of this dysbiotic microbiome changes in infants with, some potentially modifiable things. So if we can do a vaginal delivery, it seems to be closer to a healthier microbiome. If we can avoid earlier antibiotics, if we can encourage exclusive or partial breastfeeding, that can all be things that might be helpful. Now, one of the things that we do, this is always kind of a bit of a debate. So the meconium study shows that perhaps there's some microbiome risk benefits, right? Or benefits. But a lot of the meta-analyses do show that the mode of delivery is still a little bit up for grabs about whether or not it affects the risk for inflammatory bowel disease. This is the most recent meta-analysis we have, and overall it doesn't favor one or the other. So most of the time these days, if somebody asks us, I have IBD, should I get a C-section? Should I get a vaginal delivery? Unless they have a rectovaginal fistula or they have active perianal disease, it's up to the discretion of them and their OB. How about breastfeeding? We do have now longer standing analyses and newer data that shows that breastfeeding in infancy does seem to protect against the development of IBD. So that should be encouraged when we can. And how about antenatal antibiotics? So if we're able to sort of decrease the amount of antenatal antibiotics, it seems to decrease their risk for the offspring to get IBD. And same with smoking. So maternal smoking or a personal history of smoking and your mom smoked, that will increase your risk for developing IBD. So we again want to encourage avoiding smoking. This was one from DDW this year that was incredibly fascinating. This was a Danish-wide registry cohort study that basically showed that if you had the rate of IBD is highest amongst individuals, whether you had a mom or a dad that was born who had IBD, which we know that, but if the child was born and the mom had already been diagnosed with IBD, that's a much higher risk than if the mom was diagnosed with IBD after the child was born. And the same was true for the paternal side too. If the child was born and the dad already had IBD, much higher risk compared to if the child was born and then the dad was then developed IBD. So something to say about the influence of both genetics at the time and the intrauterine kind of environment probably. So then let's talk about a topic nobody ever talks about. So I have to put it on there. It's menarche and menstrual cycle changes, because patients will ask about this or want to ask about this, but we may not have much data to show them, but we can reassure them with some data that we do have. So one is that generally in the peds populations, the menarche may be delayed for quite some time, at least a year and a half. And that for the adult population, menstrual cycle abnormalities can usually precede a diagnosis. So people will say the year before their diagnosis, their periods were very off, I didn't have periods, and they're very distraught about all of this. So they may bring that up. And that the other thing too is that, when patients will have a very stable disease, they tend to have cyclical GI symptoms with their menstrual cycles that are very similar to the general population. When people have basically active inflammation, that tends to go away, So these are the scant data that we do have on it. One plug for pap smears. Patients who are on immunosuppression, they should be treated as those who are high risk. So I put the guidelines up here for your reference for it, but we do want to sort of tell their OBGYNs to kind of treat them as higher risk and that they should get more frequent screenings for it. And then how about HPV vaccination? All our patients who are adults over 15 get a 3-dose vaccine. If they're younger patients, they're under 15, but they're on immune suppression, like in our pediatric populations, then they should actually also get a 3-dose vaccine. And then the one last plug I'll make on this section is that, they may not discuss this with you, but I would highly encourage you to refer them to a, psychologist or social worker or some sort of mental health support, but that their body image and sexual health is quite poor. And you can see if you have pain, diarrhea, history of surgery, ostomies, this is quite, it can be quite limiting. So then let's talk briefly about contraception, because no talk with pregnancy, it shouldn't be without a talk about contraception. So contraception, you may feel, might not be what you may want to discuss with your patients who have IBD, but I do think from our standpoint, unless they want to have kids in the near future and they are in remission, they really should be on some sort of contraception if they're sexually active. And so those are some of the things that they need to kind of, we need to kind of help guide them on. And certain medications, we'll see until the JAK inhibitors warnings are gone away, but there may be increased risk for VTE, increased risk for teratogenicity, like we'll talk about in the main portion of the talk, or increased risk for osteoporosis. So we want to be careful with it. So the good news is the CDC actually has guidelines for this, and they basically say, try to do an IUD when you can for patients who have IBD. So that's what we want to go for. And those who want to do a more pill option, try to avoid estrogen. All right. So here I have some general ones for this, but you can just generally see that those who don't desire pregnancy for at least a year do an IUD. Those who do want a pregnancy and they're endoscopic remission, you can make a more personalized choice. But anybody who is not in remission and is sexually active should be on some sort of contraception to prevent pregnancy. So then let's briefly talk a little bit about fertility. So people who don't have any surgery in IBD, there really aren't any huge differences in fertility in the non-surgical IBD. But, and this is newer data, those who have active IBD, whether they have surgery or not, actually that decreases your risk for, or that increases your risk for infertility in the next 9 to 12 months. So active disease decreases your ability to have kids. So that is something that you should, point out to your patients if they say, I really want to have kids. I don't care how bad my disease is. You can see that there is data that shows that people who are in active flares have less kids. So that is actually very shown. And the reason for that is, if you have a lot of active inflammation going on, your body's not ready to have kids. Your body is, really just trying to do its best holding on. So what if they have surgery? So the, old standard is the IPAA. J-pouch is what we've all been taught that has an increased risk of threefold for infertility. And why is that? So the first stage of the J-pouch actually does not have this increased risk, because the first stage, you still have the rectal stump or the Hartmann's pouch, and it's the subtotal colectomy that happens and the endoleostomy. It's the second stage. So the second stage, when the surgeon has to dive deep into the pelvis, really remove all the remaining rectum, that is right next to the reproductive organs for women, and that is where scar tissue and adhesions happen. So if you had just this first stage, and then I have patients who really want to have kids, but they have acute severe UC, they come into the hospital, they have to have their colons removed, then what we do is we do the first stage, and then I let them have how many kids they want, and then we go through and do the second and third stage at a later time. So that's also a consideration. And then the third stage is the second and third stage are what lead to the infertility. So again, there's an increased risk threefold for infertility if they complete all stages of the IPA. And then this is one where you can see why. So this is from our OBGYN colleagues. I had sent them over a patient to see if they can lyse some adhesions after she couldn't get pregnant. And they sent this video to me to say, never send them another patient like this again, because all they saw after 5 hours of working on this patient to create this one tiny window was just these adhesional sheets that just filled the entire abdomen. And she underwent IVF, did fantastic, and then somehow, for her second kid, just naturally got pregnant, actually. So, it goes to show, but in general. And then the one other slide I want to put on here before we talk about pregnancy is there is a hormone called AMH. This is what people refer to as their fertility hormone. So patients may, if you go to Coachella, they have fertility vans, and you can go and get your, fertility checked in that van. And this is what they draw. And you can see that in general, for all women without IBD, the AMH starts to lower somewhere around age 35. So that's where people say, oh, your fertility might decrease after age 35. In those who have Crohn's disease, it actually tends to be a little bit earlier. UC tends to be about the same. So with IBD, it does tend to happen a little bit earlier, the drop off. And if they're on active inflammation, it's even lower. All right. So again, more reason to tell your patients to really try to get things under control before they have kids. So then let's talk about sort of the meat of the talk, which is in pregnancy. And why is this an important thing to generally talk about? So when you look at in the US, when patients get diagnosed with Crohn's and ulcerative colitis, it happens really right around the time or right before the time that the majority of people in the country are having kids, all right? So even if it's not in their plans in the next 1, 2, 10 years to have kids, it's something that they always think about. And that misconceptions are really common. Patients are always like, oh, medications are harmful to my baby, and I can put up with the symptoms as long as my baby is safe. But you really have to push back and say, well, what are the risks for uncontrolled disease? It's a lot. It's a lot. So even if you are perfectly quiet on the inside and endoscopically in remission, patients with IBD are higher risk. There's already a higher risk for preterm birth and low birth weight, even if you're perfectly quiet. All right. So if you have flares, that increased risk goes up quite a bit. Or if you're not in active remission prior to conceiving, that risk goes up quite a bit for preterm birth, low birth weight, miscarriage, stillbirth. So if you take away only one message from this talk, endoscopic remission at conception is the better outcomes. And I want to say, just think internally when you see this picture. When I first saw this picture, this is from this beautiful website done by a Spanish gastroenterologist. She has these beautiful illustrations. I got so excited, like, look at all these medications that are available now for IBD. But I think some people may look at this and say, oh my God, well, look at all these medications that are available for ID and how many of these are safe and how many of these are not safe, right? So for us, it's an exciting age, but you do have to kind of be a little bit kind of cautious with some of our newer medications out there. Some of our old tried true medications that we know are not safe, thalidomide, methotrexate, all right, we're good about those. The ones that we do know are really quite safe, mesalamines, the old one version of mesalamine that had a unfavorable coding is not in the US anymore, but mesalamines are safe. Thiopurines, especially nowadays where we can monitor levels, are safe. Biologics as a whole are safe. Steroids, prednisone with appropriate caution, obviously, but generally are safe. How about some of these newer oral immunosuppressive agents? So this is where there is a risk-benefit shared decision-making that we'll talk about in a second. So the landmark study that was published in 2021, funded through the Crohn's and Colitis Foundation, is the PIANO study. And it really showed that biologics and thiopurines are really quite safe in pregnancy and lactation, all right? It's active disease that is the issue. And, you know, in general, I have these charts for everything, but I want to kind of point out some changes that have been made to the charts. So in the past, we would try to time biologics to be given where there's a little bit of a window of breathing room in the last trimester. But I will tell you these days, all of us who practice this, we don't do that anymore. We just try to time it to where they're not actively getting an infusion as their delivery date is happening. But we usually really don't time this out. And I'm happy to talk in more detail about it with a specific medication, et cetera, in the future with anybody. But in general, we really try not to change their third trimester, because what we were finding is that we would overextend and patients would flare, and that we were also under delivering drug after they deliver, and a lot of patients were having postpartum flares. So now we leave most things alone. We do have some updated registry data on vedolizumab and ustekinumab, and they're really quite similar to anti-TNFs, so they're safe. So how about the newer oral small molecules? So this is tricky. The trickiness, it comes from that we just don't have that much data. And the animal data we have doesn't look great. It's not terrible, but it doesn't look great. And depending on the drug, so for tofacitinib, they had increased risk for congenital malformations at a dose of 6 times the maximum human dose, right? But for upadacitinib, that increased risk for congenital malformations at the lowest human dose, right? So there's a variation for it, right? But these are in animal studies. The data for human studies, not much out there, but actually it looks okay. It looks okay. So this was an oral that was done by Dr. Mahadevan, this DDW, that looked at pregnancy outcomes after maternal or paternal exposure in tofacitinib ulcerative colitis in their drug clinical program. Again, not huge numbers, but what they did show was that it generally was safe, all right? And there was no really reports of fetal death, congenital malformations. Again, low numbers, but it's safe. So I think where we are kind of heading, and this is what I want to preface the next portion of the talk with, is that with some of these oral small molecules, if there's not better options, we may actually want to consider continuing in certain patients. So where are these recommendations coming from? So there are many bodies or collaborative groups that work together around the world in pregnancy, and everybody had kind of the Europeans had their own guidelines, and then the Americans had their own, and then South Americans had their own. So what they all did was they came together. It was funded by the Helmsley Trust, and they all came together to create a PIANO Global Consensus Conference. So Dr. Mahadevan, Dr. Kane from Mayo, and Dr. Marla Dubinsky and Dr. Abreu were the 4 from the United States, and then they picked these experts throughout the world. They had patients involved, they had pharmacists involved, they had maternal fetal medicine involved, and they had a big conference at this DDW. And here are some of their recommendations. Now, they just did this, so the actual publications from this likely will not be out until at the earliest the winter or the spring of next year. But these are some of the hot takes, and including one that I think is one that's going to be really exciting about vaccines. So Here are some of their consensus statements that they should see. So the consensus statement number 1, active disease, like we have been talking about. Pregnant women with IBD with active disease really need to start or optimize appropriate therapies, as in non-pregnant patients, with the exception of ones that we know are not helpful, for it. So basically be more concerned regarding active disease than active medications. 2, thiopurines are still safe, but the FDA in April of 2024 did have an announcement of a rare risk for intrahepatic cholestasis of pregnancy with thiopurines. So this personalized a little bit. Just make sure you're not overdoing it on the thiopurines, or if they're combination therapy and they're doing phenomenally well, maybe drop that thiopurine for a period of time. But in general, you can still consider them safe. Antibiotics, if they need it for fistulas, infections, safe. Calcineurin inhibitors like cyclosporin and tacrolimus, safe. Just monitor them closely. How about biosimilars? I didn't put this on there, but there was an abstract from Millie Long at North Carolina that showed that biosimilars in pregnancy were just as good as the parent drug. Anti-IL-23, safe, and that we are going to assume that the newer anti-IL-23 therapies are also safe based on mechanistically speaking. And then how about ozanimod and etrasimod? So these S1P agonists. So they did say we should probably discontinue them for at least 3 months prior to conception, unless there is no other effective alternative therapy. I will say in our experience that ozanimod and etrasimod, fantastic medications, but typically there usually is an alternative that we can use. So it is my practice to switch to something else in this case. How about the heavy hitters, the JAKs? So they have this consensus statement that really we should try to discontinue the JAKs at least 4 weeks prior to conception, unless there is no other effective alternative therapy. All right. Filgotinib, again, this was an international consensus, conference, so it's not approved for IBD in the US, but it is in other places. So the main consensus statement for the oral small molecules is that shared decision is imperative. If electively switching therapies incorporate time to transition and establish remission on other effective and safe therapies, if there's no other effective alternative therapy, continue therapy, given the totality of data supports stringent disease control, is likely more important than the rare outcomes of fetal congenital anomalies. All right. And then this one I wanted to include for you guys, because I think this may hit most of the patients that you have, is just what happens if your patient flares during pregnancy. And especially if they're anti-TNF naive, start the anti-TNF, unless they're about to be going to deliver in the 3rd trimester. Okay. And then let's talk a little bit about delivery and postpartum care. So mode of delivery, again, like we had said before, anybody who has any active perianal disease, they have an active ceton in, they developed a new fistula, or they have a history of a rectovaginal fistula, these are patients you don't want pushing and having these higher order laceration and tears. So those recommend a cesarean. Somebody with an IPA or J pouch. This one is tough. I would say err on the side of a cesarean delivery if you're unsure, but there are some patients who successfully delivered prior babies. If the baby is head down, smaller, they have good pelvimetry, this patient has had a couple of kids already, that might be somebody that, you just tell them to be careful and try not to use forceps or a vacuum. And then really everybody else can have vaginal delivery, including those with ostomies. All right. Postpartum, you do want to try to ask them to minimize NSAIDs because they can trigger flares. There was one small study looking at a Toradol one-time dose was safe. Lactation, again, safe, protective breastfeeding. And really sort of the only thing I would add is that a lot of supplements include fenugreek in them for lactation, and that can trigger flares. So try to look for a fenugreek-free supplement for it. So, and then here's some last couple of recommendations from the Piano Global Consensus Conference. They recommend that women with IBD undergo preconception counseling because that has had many, many studies that show that it improves medication adherence, reduces the risk of disease relapse, it reduces the risk of low birth weight infants and preterm infants, all right? And that surgery, whenever you need it, get it done if it needs to happen. the C-section recommendations like we had discussed. And then this one is kind of hot off the presses. So this one, we were always said that the baby should avoid any live virus vaccines if they were born to any advanced therapies. We used to just say biologic, but now we have to say advanced therapies, right? For 6 months, all right? So here, they're coming out with the recommendation that rotavirus can actually be offered to infants exposed to anti-TNF agents in utero. And the same goes for, we're extrapolating from anti-TNFs to anti-integrin and the anti-ILs. So you can say now, you can go ahead and get the rotavirus vaccine. There's enough evidence that really show that it doesn't seem to affect. But again, maybe not pertinent for us in this country, but live BCG vaccine still should be avoided in other countries. And then infants exposed to JAK or S1P modulators can still receive live vaccines, but they just can't have them for a month. But in the US, we don't give any live vaccines in the first month anyway. And then lastly, they recommended that all women with IBD are considered high risk and really document remission and medically optimize prior to elective one. Then I'll leave on this last note for pregnancy, just that this is a really nice sort of, just sort of paradigm of what you should be doing kind of during pregnancy. And I know they'll have all these. And then because we should talk about menopause, but there's nothing really to talk about menopause. This is the last slide for it. There's very scant data in menopause. So if anybody wants to help, look into this, it would be fantastic along with us. We are seeing slight needle movements that maybe there was one newer study that came out. It's not the best, so I didn't necessarily include it in here, but that maybe giving some hormone replacement therapy calms the IBD down. So I think this is to say we don't have enough data, but that I think I am all for patients if they feel like they need HRT to just start low and slow, much like their GLPs, and just keep a close eye on everything. So these are my top 12 pearls for caring for women with IBD. And the main one I want to kind of also say is number 12. Number 12 is don't hesitate to reach out to your IBD and MFM colleagues. We are all very nice, and we really, really enjoy taking care of complex cases. And so if you see all this, you're like, wow, this is great. I would love to talk about contraception. I would love to talk about this, but how can I do that in my 10-minute visit with this IBD patient who's flaring, who I need to start on upadacitinib, then that's what we're here for. So please feel free to reach out, and we are very happy to help out in any way that we can. Thank you so much for your time.